Good afternoon, everyone, and thank you so much for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds that's generously sponsored by California Health and Human Services and the California Medical Association. The Grand Rounds today is about COVID-19 and Omicron. And just a reminder that today's session and for the rest of the year, these sessions will only be 1 hour long as opposed to our previous 1.5 hour format. Next slide, please. These are our disclosures. Next slide, please. And this is our agenda today. Next slide, please. Do note that CME is being offered, and just as a reminder, you have to complete the survey after the webinar ends. We'll send that out to you, and then you can get your CME certificate. Next slide, please. So the pace of this pandemic continues to be fast and furious, and as we're hoping for a breather, and it looks like maybe we have one, we're so lucky to have Dr. Erica Pan, our California State epidemiologist, to continue as usual to catch us up on the current epidemiology, the progress of our vaccinations, medication updates, and so much more. And today we're especially excited that Dr. Pan will be joined by Dr. Lindsay Marr. Dr. Marr, who's here today all the way from Virginia, is a widely publicized expert on indoor air who will help us understand how to think about the science and the engineering behind masking and how interventions in indoor air quality can impact the transmission of COVID-19 and other respiratory viruses. Please do submit any questions you may have on the presentations, and we'll go over these and many of the ones that you've submitted ahead of time as we have time. And I do want to note also that handouts of our slides are available already for you to download. So for our first presenter today, we welcome back Dr. Erica Pan. Thanks, Erica.
Great, thank you very much. Let's go ahead and go to the next slide. And go to the next slide. It's a pleasure to be here again with all of you, and today I want to do my usual kind of update on the epidemiology here in California and our vaccine progress with a little focus on pediatric data given exciting news that is coming our way. Wanted to highlight, to complement Dr. Marr's talk today, our recent California masking case control study in the community, and just some other recent updates from the state. Next slide. So this is our epidemic curve that I show you, I think, every time I'm here, and in all my talks, I kind of like this sort of summarizes sort of where we've been with the pandemic and a few different parameters we're always looking at. So to orient you, this is from the very beginning until most recently, and you can see the blue line here is our cases. So we actually peaked around January 4th as far as the highest date of people who reported when they started their symptoms or when they were tested, over 150,000 cases that day on January 4th. And to give you perspective, last winter surge, our peak was around 60,000, so over 2 times the total number of cases. But that is thankfully decreasing dramatically, as you can see here. What's not on this slide is test positivity, which is down to 8.8% for the state of the 7-day average today. And then the smaller lines that do get sort of dwarfed by the huge number of cases we saw are the orange line is hospitalization. So you can see proportionally compared to prior surges, thankfully, the hospitalization numbers were much lower compared to previous surges. And you'll also see that they are finally declining a bit. And one of my other slides will highlight a bit where we are on that. The red line is deaths, and they're not proportional here, but just to be able to show you. And you can see, though, when you compare, though, even though these are not to scale, but the scale is consistent across the pandemic, that the deaths were much higher proportion of cases from the last winter surge to the Delta surge to now. So that is reassuring, but we are still seeing, daily deaths as we catch up with the time lag on that. And then the lowest line in black there is the ICU census over those different days, which thankfully has been relatively flat compared to prior surges. Next slide. And this, just to orient you again as well, is I've also shown this several months. This helps give you a snapshot of our overall statewide hospital census, which is the lower right-hand panel in blue, and then some of it by regions. And the top line that is just a single line with a couple dashed is really our overall hospital census And the dashed lines are when we are at 10%, our sort of baseline, when we have been at our nators, or 20% above our baseline hospital census of all patients. And you can see that actually with this Omicron surge, even though, yes, it was milder, because of the pure number of cases, we were over 20% statewide, and we still are, and especially in Greater Sacramento, the San Joaquin Valley, and Southern California. And you can see compared to the historical winter surge. And then the lower solid peaks are actually the percent of patients in the hospital that are positive with COVID. So we've seen in many of our surges over 20% of patients in the hospital. You know, as many people have been asking and looking at, there of course is how many of these are incidental versus with COVID as far as for COVID with Omicron. There are many estimates out there. Some say roughly half, but given that it still has put our hospitals over the edge and over 20%. And our understanding is that during a serious flu season, it might be like 5 to 7% above baseline, but this has really stretched our hospitals. And again, they are improving, as you can see on this slide, but still quite above and quite stretched with less staffing than we've had in prior surges. And then our ICU capacity is something we watch very closely statewide. We've been relatively stable, but the San Joaquin Valley has been under 10% for several days now, and watching that closely. Next slide. And then this is another slide. Just wanted to kind of put this in perspective. A lot of people have been talking about, well, isn't this just like the flu? How does this compare to the flu? This is looking at mortality, and to orient you to this graphic. So the gray bars are the total all-cause deaths with the absolute numbers. And this is from 2017 to the present. And then you can see the different colored lines are pneumonia, flu, ARDS, or COVID-19. And so you can see our worst very serious flu season was 17-18, and that was an H3N2, one of our really serious flu seasons where our ADs were stretched, the wall times were high. But even then, the flu percent of deaths was only about up to 5% or so of all-cause deaths. And you can see the peak in the overall absolute number was higher than most of this other time until COVID. And then you can see last winter's surge, we were, 45% of all-cause deaths. This is based on death certificate. And it's been anywhere during these surges from 15 to 45%. So still dramatically higher than flu as far as at least confirmed causes of death, and you can again see the overall absolute number of deaths. And so this is really, again, to illustrate that we still aren't back to severity levels that are more similar to flu. Next slide. And then we have updated our dashboard, and there's a link on these slides to show not only the difference between unvaccinated and people with 2 doses of mRNA or 1 dose of Johnson & Johnson, but also boosted individuals. And you can see here the dramatic difference. So hospitalizations, actually, you are 15 times more likely to be hospitalized if you're unvaccinated compared to someone who's boosted, and you're 30 times more likely in the deaths versus boosted individuals. So you can really, again, see how effective boosting is to decrease those hospitalizations and deaths. Next slide. And then this is kind of just to show you where we are as far as our vaccination progress in California by age. And you can see, and this is going to be a theme of my talk today, we really need to make progress on our kids and our 5 to 11-year-olds. We are, as you can see here, getting close to 2/3 of our 12 to 17-year-olds at least are vaccinated, which is great, but we need to make a lot of progress in 5 to 11-year-olds. And then as far as boosting, over almost 55% of 12 and over are boosted who are eligible, and then 72% of our 65 and over. So those are encouraging, but still want to continue to increase that number because of the data I just showed you. And then the table here just sort of shows, again, about 1/3 total of 5 to 11-year-olds, and over 72% have gotten at least 1 dose as far as that lower table. Next slide. I think the other important theme, though, too, is looking at equity. So many of you remember and in general, we use something called the Healthy Places Index in California. And this shows you by age. The green is the sort of wealthiest, most resourced quartile, and the light blue is the least resourced or the poorest neighborhoods. And you can see the disparities are the highest at our lowest ages as far as who's actually vaccinated. So again, this is really something we need to continue to move the dial on, especially in our younger age groups. Also meant to mention in the earlier slide, one of the other big news, as all of you likely have heard, is that Moderna was endorsed for full licensure last week. So that's other updates and vaccine news. Next slide. So this is a flyer, and there is a link as well to this in the handouts that you can use as a flyer, but really just, again, illustrating that COVID-19 actually is a childhood illness. Thankfully, it has not been as serious in kids compared to adults, but it is still causing morbidity and mortality that are concerning. 4 times more deaths than the flu nationally, and for unvaccinated kids, teenagers, 11 times higher risk of hospitalization. And then again, our equity issues are really dramatic. Our poorest neighborhoods are far behind. Only 21% of our children in California are vaccinated compared to 64% in our 5 to 11 age. And 2/3 of these younger children are not yet vaccinated. Next slide. What are some other pediatric data to highlight? So MASC in California, we actually have had over 800 cases in California to date. As you know, it usually presents several weeks after COVID-19 infection, often after a very mild infection. And you can see again, as far as the peak in cases, which is the black line, overall cases, and then MISC is the blue line. So it typically does take several weeks, and so we may see more coming in now. It's still early on. We're hoping to see less than we did after that winter surge last year, but watching that closely. And I think really important to emphasize, half of kids who get MISC are previously healthy kids with no other underlying conditions. Half are admitted to the ICU, and we've had 8 deaths so far of MISC patients. Some of the comorbidities in the half that are noted are obesity is the most common one, and then other lung disease, congenital heart disease, or other congenital malformations, seizures, or cancer. Next slide. And actually a point, and in the supplementary slides that will get sent out, we have looked actually, if you go back for a moment to the MIC, just a couple other things I wanted to highlight are there's also a lot of disparity here. We have a very disproportionate number of in quartile 1, 47%, almost half of our cases are in our least healthy places index, and disproportionately in our Latino Black population. And our vaccination status, when we looked at just the 12 to 17-year-olds after the time period when 12 to 17-year-olds were eligible for vaccine, 89% of those cases were unvaccinated. And there's also a link and a slide in your supplemental slides of a recent MMWR in January also about the effectiveness of vaccines to prevent MISC. Next slide. So trying to look at hospitalizations and severity of pediatric hospitalizations here in California. This again is from the last winter surge to now, and looking at PICU beds. So clearly we did see a large jump in the percent of COVID positive patients in our PICUs with this Omicron surge. So we see here that over about 18% during the Omicron surge of our PICU beds were filled with COVID positive patients. And in those beds, even if it's an incidental finding, often what we've seen in both adults and kids with underlying diseases is a COVID infection can certainly be something that tips someone over the edge. Thankfully, we have not stretched our PICU bed availability, which is the red line here, or staffing, in the same way we have with our adult patients, but we did see again this jump. It is also reassuring to know, as far as overall hospitalizations, kids have comprised only 2 to 3% or so of our overall hospitalizations over time in California, including during this recent surge. Next slide. And then what about pediatric deaths? So, and this slide was as of the end of January. I know we've had at least 1 other death since then. So 51 deaths, sadly, here in California. Here's some information here about the median age of 10. There have actually been 12 infant deaths. And you know, about 60% have had symptoms. Some are unknown. And as far as underlying conditions, about almost 2/3 of the deaths reported to us did report at least 1 underlying medical condition. And the most common that you can see here are lung disease, obesity, other genetic or congenital disease, or neurodevelopmental disorders. And then, of course, immunocompromised, and then asthma was in there as well, as far as pediatric deaths. And then it's also notable that during one of the ACIP meetings last fall, it was noted that COVID-19 was equivalent to the 8th leading cause of death in children 5 to 11 years of age when compared to 2019 data. And that was actually before the Omicron surge. I haven't seen an updated comparison to that. Next slide. So to shift gears for a moment, and again, to complement the great work that Dr. Marr will be sharing with us, wanted to highlight some work we're really proud of. Our team, in collaboration with UC Berkeley School of Public Health, did a test negative case control study from February to December of last year, and enrolled initially over 3,000 individuals, and then did some different analyses looking at frequency of mask use and type of mask use. Essentially all the indoor people were asked in indoor public settings, did you wear a face mask all, most, some, or none of the time? And again, these were from our database to call people who are either tested positive or had tested negative. And you can see again, or you'll see in some future slides, that in all these, there's basically a gradient, which is not surprising, but there was a really illustrated dose response to the more often you wear a mask, the less likely you were to test positive. And then a subset since September but although pre-Omicron through December 1st, were asked about in indoor public settings, what type of face mask did you wear? Did you wear a respirator, a surgical mask, or a fabric mask? Next slide. So here's kind of the illustration of the dose response. So when people were asked about masking frequency, if they were always wearing them, it was 56% effective, as opposed to sometimes or most times. So again, there's a dose response here in showing how often people wear masks, and the more often you wear them, the more protective it was, and the least likely you were to test positive for COVID-19. Next slide. And this is the infographic that the CDC had put with it with the MMWR that came out last Friday. And this was actually, again, in that subset I mentioned of people who reported always wearing a mask in indoor public settings. Actually, sorry, there's an overall almost half as likely for wearing a mask or not overall. And then when looked at the different kinds of masks, you can see that respirators, not surprisingly, but again, great to see this in the community as opposed to in the laboratory, showing that people who wore respirators were 83% lower likelihood of testing positive. And then you can see the gradient here as well. Next slide. So just an acknowledgement, we have a huge team here at CDPH that worked on this, and again, in collaboration with Dr. Joe Lunard at UC Berkeley School of Public Health. Kristen Andrejko has been doing this project within our CDPH, and again, leading a team to conduct this large study. So really proud of this work, and really helpful again to see something in the real world and here in California. And we'll be continuing to do this study case control for looking at all kinds of things as far as what are other exposures and risk factors associated with testing positive for COVID-19. Next slide. So what are some other recent updates? We have updated our guidance in early January for schools to really start to think about knowing that in the midst of the Omicron surge, trying to do individual case and contact investigation was very resource intensive in schools, and just so much transmission, causing a lot of difficulties in actually trying to be able to do that. And also, very importantly, as we think about moving forward, with the incubation period being so short for Omicron, by the time individuals are notified that they've been potentially exposed, they might already be close to the end of their incubation period, or certainly it's time to focus on just getting tested of symptoms or getting tested to see. So the school guidance shifted to group tracing as an option, and that's one way we've really tried to shift our school mitigation options to be really nimble with the changes in the COVID variants, and also keeping kids safe and successful in schools. And then yesterday, we kind of highlighted that we've had this gradual return to our pre-Omicron, pre-mid-December rules. So the healthcare worker isolation and quarantine guidance reverted to what it was before mid-December, and very similar to the CDC guidelines. So that was effective February 1st because it was a temporary measure. And then the visitation requirements, we increased those during Omicron to require vaccination and testing, and those have now reverted back as of yesterday to pre-Omicron requirements. And then we did announce yesterday as well that as of, go back again. After February 15th, the universal indoor masking requirement will only be required in certain specific settings. So healthcare settings, residential congregate settings, schools, childcare, There's a federal law about public transportation, shelters, jails, and prisons. And then the mega events is going to revert to the size had gone down to 500 indoors and 5,000 outdoors. And it's going back to what it was before December. We really need to continue as far as some things looking forward, closing our equity gaps, as I showed you, increasing vaccine and booster coverage. It's also, we do think in the coming month or so that treatment availability is going to be increasing, and really thinking with our local health departments about prioritizing our resources, increasing automated notifications, and really focusing any public health investigations on cases in highest risk settings and situations, and focusing outbreak investigations in those settings. Next slide. And then just a call to action again, very exciting that we will be seeing vaccines for our less than 5-year-olds very soon. There's a VRBAC meeting on February 15th to discuss this. So we could be getting vaccines here in California by the end of February. So the time is now to be vaccinating kids. Here's another flyer and link on something you can share widely, but we see that 40% of VFC providers are not actually giving COVID-19 vaccines. So really wanting to enroll more of you as primary care providers, especially for these younger children. Families are going to want to be in your offices talking to you about getting vaccinated, and we really want to minimize any missed opportunities. And in surveys, you know, all different surveys, people really do say, and not surprisingly, that their primary care provider and their clinical providers are who they trust most to make these decisions. Next slide. And so with that, we will be preparing sort of in public health to try to be very flexible and adaptable as things move forward, and looking to being able to adapt to the next variant and hoping that it will be milder, but not knowing, and being ready to return to some of our other core public health functions, but also being nimble and elastic and flexible and resilient to be watching for the next waves. And there will be more announcements forthcoming as far as other planning from the state for other guidance and changes as we adapt. Next slide. And with that, I will stop. Thank you, and happy Lunar New Year to everyone.
Thanks so much, Erica. I have to say I love that last slide, because I do think that you are Mrs. Incredible. So well done on that. Now I'm so excited to welcome Dr. Lindsay Marr. Dr. Marr is the Charles P. Lunsford Professor of Civil and Environmental Engineering at Virginia Tech. Her research group studies viruses and other microorganisms in the air, and she's worked with many collaborators, including the CDC, the National Academy of Sciences, Engineering and Medicine, to update conventional wisdom about virus transmission and recommended guidelines for reducing the transmission of COVID-19. And she's been widely quoted and published in this, and we're very grateful for her work. Dr. Marr holds a BS in engineering science from Harvard, a PhD in civil and environmental engineering from here in California at Berkeley, and she completed her postdoctoral training in Earth, atmospheric, and planetary sciences at the Massachusetts Institute of Technology. So we can't wait to hear more, and thanks for being here.
Thank you for the introduction. It's a pleasure to join you today. I am originally from Sacramento. My father recently retired from being a pediatric surgeon, so I have a direct connection here. Next slide, please. I want to start out by providing a couple slides worth of background to help dispel some myths that are circulating among the general public about how the virus moves around and what actually works, and to increase understanding. And so viruses are carried in respiratory particles of varying sizes, and we know how these behave in the air. The naked virus by itself is 0.1 microns in size. For reference, your hair is about 50 to 100 microns in diameter. But the virus is not naked when it's expelled from your body. It's in droplets of respiratory fluid that range widely in size, anywhere from 0.2 to 100 microns or more. And so for scale, I'm showing a droplet that's half a micron carrying a virus. That droplet is not just water. It contains salts and proteins, surfactants, other things that are in our respiratory fluid. Even if all the water evaporates, there is still a lot of that other stuff compared to the virus. So we do not have naked virus floating around. Next, please. There has been a kind of error, I guess, let's say, that was propagated over the past 5 to 10 decades about kind of what size aerosols are and whether they would fall to the ground quickly. So I'm showing a graph here just based on physics calculations showing the trajectory of a 5 micron droplet, which has been considered the cutoff between what are called aerosols and droplets, but really that should be about 100 microns. And this is at a low indoor air velocity. Even if the air feels still, there's still small movements of the air. So the air's moving indoors at, let's say, 5 centimeters per second. That's on the low end. And if we have a 5 micron droplet released from a height of 1.5 meters, about the height of my mouth when I'm standing, that would actually move around over 100 meters before it hits the ground. So it's falling very, very slowly. It's not like this large thing that you just see falling to the ground within seconds. And then if you look at the 10 micron droplet shown in yellow, you can see that that still travels can travel 25 meters. You have to get up to sizes of 20, 30, even 50 microns or larger before you get something that's going to fall to the ground within 1 meter, 1 or 2 meters, 3 to 6 feet. Next, please. So, you know, we've talked about transmission at close contact and being dominated by large droplets, but in fact, when someone breathes or talks and coughs and sneezes, they're releasing tons of tiny droplets that some will evaporate and some are just tiny to begin with, and we call those aerosol particles or aerosols. And so when you're close to each other, you can have transmission by the kind of traditional large droplet spray, where this visible droplet flies from my mouth into the eyes, nostrils, or mouth of the person opposite me. But I'm also releasing hundreds of aerosol particles for every large respiratory droplet, and those are going to behave like cigarette smoke particles. So they're more concentrated close to the infected person, and then that person opposite me is going to breathe in a lot of those when they inhale. And it's hard to separate these two observationally, the two different routes, but we can model what's going on using physics, and exposure is dominated by inhalation of aerosols at all but uncomfortably close distances. Next, please. So masks are not sieves, they are filters. I saw a photograph circulating showing a chain link fence and a tiny bird sitting on there just flying right through and saying, oh, masks don't work, the virus is tiny, it goes through the holes. Well, here's what really happens. With filtration, it's more, actually, let me go back to the chain link fence idea. It's not just one chain link fence, it's a whole stack of chain link fences that are placed maybe an inch apart, and the bird is actually a tiny road runner that's going through full speed and needs to navigate a course through these chain link fences, which are not lined up, and there's a ton of them. And so what's happening is that the respiratory particles carrying the virus get trapped by these different mechanisms. They can veer off course and crash into the fibers of the filters. They can come close enough to the fibers that they end up bumping into them and sticking. The tiniest particles actually have some random motion to them called diffusion, and they will kind of wander off the path of the streamline and crash into the fibers. And then there's, of course, electrostatic attraction. Another kind of misconception is that, well, if something can filter out particles larger than 0.3 microns, and everything smaller gets through. And so on the right-hand side, I'm showing the collection efficiency of a filter as a function of particle size. And it's the black solid line that has that U shape. And there's actually a minimum around 0.3 microns, which is why we talk about that size. It's the hardest particle size to filter out. And actually, for particles that are smaller than that, next please, the filtration efficiency is actually higher. So, you know, if you are worried about a naked virus shown there at 0.1 microns, it's actually easier to remove that than it is something slightly larger, and that's because of the diffusion mechanism. Next slide. So we've had a lot of studies now on masks. The overwhelming evidence suggests that masks work, in that they reduce transmission. They do not eliminate it though. So I know people like to say, oh, masks work or masks don't work. It's not 0 or 100%, it's somewhere in between. So this is a study published in Science in 2021, looking at different mitigations in schools. Next. And they found that, so they're looking at the odds ratio here of these different interventions. So anything above 1 means there was an increased risk of, the endpoint here was looking at COVID-like symptoms, and then anything less than 1 would be a reduced risk. Next, please. And you can see that student masking and especially teacher masking both had odds ratios that were less than 1. Maybe there was some overlap with 1, so it's not clear whether it was significant. But other measures were were associated with reduced risk of those symptoms, especially the daily symptom screening. And then we can see that some actually showed an increased risk. That was desk shields, so the plexiglass barriers, which, in general are really only useful for close, brief face-to-face interactions. Otherwise, they get in the way of good ventilation and can make things worse. Next slide. So what about that CDC study? The Virginia governor's order, when we had a new governor who came into office in January, and his executive order was trying to say that masks were not needed in schools, and he cited this study and claiming that, okay, there is no effect of masks for students. This study, which took place in Georgia, looked at COVID-19 incidents, looked at the rate ratio for different policies in schools. And when they required masks for teachers and staff, you can see that the rate ratio was 0.63, so it was 37% lower, the COVID-19 incidents, and that was significantly different from 1. When they required masks for students, they did see a 21% reduction rate ratio for COVID-19 incidents, although the 95% confidence interval did overlap 1, and so they said, okay, it's not significant. And then notice that ventilation improvements were also associated with reduced COVID-19 incidents. So there was a reduction in this case with masks for students. It wasn't significant, but there have been plenty of other studies showing mostly significance. There is a kind of small and I would say small beneficial reduction in transmission with masks in schools. Next, please. So there was another study in MMWR looking at COVID-19 outbreaks. I believe this was in Arizona, and they found that schools without mask requirements were 3.5 times more likely to have COVID-19 outbreaks. And then Dr. Pan covered the study shown in the lower right-hand corner, so I'll skip ahead to the next slide. Here's the thing, any mask is better than no mask, and masks vary widely in their effectiveness. So your best choice is a respirator, which could be an N95 or KN95 or KF94. KN95s and KF94s are the Chinese and Korean versions, respectively. They have ear loops instead of straps that go around your head, so some people may find those more comfortable, although personally I prefer straps around the back of my head. The ear loops bother me. From what we've seen in testing in our own labs and the literature, and also the Mask Nerd on Twitter, who's done some great testing, people in the general public, my daughter, for example, who's 10 years old, I gave her 5 seconds worth of instruction. You can get 90 to 95% protection with those. Now, if you go to a medical mask, what people call a surgical mask or the procedure mask, you'll see anywhere from 20 to 90% protection. And that really depends on the fit of the mask, how loose it is, and whether you've done any tweaks, which I'll talk about in the next slide, to improve the fit and reduce leakage. That mask is actually made of the same type of filtering material that's in an N95, but it obviously is not designed to have that nice seal to your face. Cloth masks can range anywhere from almost having no effect to, if you have a cloth mask with a good filter, you can get 80% protection. And so here are the things that I think that people should prioritize when picking a mask. One is comfort, because if it's uncomfortable and you're not going to wear it, it's not going to help you. The second is fit, because those gaps around the sides, if there are any gaps, then things can just short circuit and go in and out, and you're not getting any benefit of the mask. And then the filtration capabilities of the material. Next. So here's some tweaks to improve performance of a mask. I know there's discussion about equity, and not everyone can afford getting enough KN95s or N95s to have around, but surgical masks are available free in lots of places, and here's some things you can do to improve performance to take it from 20% up to 90%. So one of the most important things to do is to bend the nose wire to fit closely around your nose bridge, because you get a lot of leaks up there. You can also make the mask a lot tighter if you use toggles, like little pinch things, or tie the ear loops to make it tight and pull it against your face. There's some that have straps that can go behind your head and kind of hook on to the ear loops and pull it tight that way. Next. Another thing you can do is what CDC calls the knot and tuck method, shown here. So you make a knot in the ear loops that's actually close to the mask, and then you put those on and you kind of fold and tuck the excess material up against your cheeks. You can get, I think one of CDC's studies found that that brings your efficiency up to maybe 70%. Next. Braces or fitters that you put on top of the mask to help seal it are very effective. You can get up to 90% or better protection if you have that type of thing over your mask. There's something called Fix the Mask, which is provides a pattern for free, and then you need to get the material and you can kind of cut it out and put this strap over your head. Next. And then there's double masking, where you would put a tight-fitting cloth mask on top of the surgical mask, and that cloth mask is actually serving to really to improve the fit of the surgical mask. Next. So as I mentioned, these modifications can improve performance of just a loose surgical mask by itself, which might be 20 to 50% effective, and you can get up to 70 to 90% effectiveness. Next. There are questions about respirator use in the general public. So I know there are strict rules about N95 use in healthcare settings and other workplaces, which makes sense for those types of settings where the employer is obligated to protect the employee. But it's still an N95 in the general public is going to be far better than other options. And so, as I mentioned, you know, I have not been fit tested for an N95, but I grabbed one. Actually, the 3M V-Flex, which I find very comfortable. I've worn for many hours on many different trips, and I got better than 99% protection in the laboratory. So I punched a hole in it. There's special ports you can put in there, and then I measured particles outside and particles inside. Did this with my daughter. She got better than 95%. Now, how long can you use these? So I know in healthcare you use it once and you discard it. They're actually designed to handle a large amount of particles. And so they have to handle enough before they really lose their filtration ability that you could wear it in a heavily polluted city in China for 200 days. So really that's not a limiting factor. The limiting factor is going to be the straps, which will stretch out or break before you ever kind of exceed the filtration capacity of the respirator. It's likely that your respirator is going to get torn or get ripped or creased or otherwise physically damaged, in which case you should replace it, or if it gets visibly soiled, or if it gets soaking wet. I've used some for well over 40 hours, over kind of multiple trips or to the store or sitting in a concert, in a classroom, and it's been fine. The contamination issue remains. We don't know how big a threat that is. We're looking at, there are studies showing that the virus can survive for a long time on an N95. That's where they pipette like large droplets, more than you would actually have on there if you were breathing through the mask. So they pipette these large droplets onto the N95 and find, oh, it's still there hours or days later. We're actually undertaking a study right now where we're nebulizing the virus, and we actually have the mask material set up so we're pulling the aerosolized virus through the mask, so getting it on there in a more realistic way and a more realistic amount. And we find that so far, the amount of virus that's deposited on there decreases by a factor of 10 in 30 minutes. And that's when we actually take the N95 and like soak it and sonicate it put it into liquid and actually vibrate it and try to get all the virus off of there. And I think if you're just touching it, even less is going to come off. So I guess we're still undertaking that study, and we look forward to reporting the results once we're finished with it. Next. So why are masks so important? Well, they aid in source control. This shows a couple of people. Let's imagine that the person on the left is infected, and so she's talking, she's releasing, the occasional large droplet, but lots of aerosols. Those are concentrated like cigarette smoke close to her. If she's in a poorly ventilated room, those have accumulated in the air. Next slide. So if we put a mask on her, then she's releasing far less into the room. So the person who's close to her will be exposed to less, and there will be less that accumulates in the room. Next slide. Masks also help for personal protection, and then distancing will also be shown here. So now we're back to the original scenario, and then next slide. So now we're going to put masks on to the other people, and that's going to reduce the amount that they're exposed to. And we've distanced the person who was close. Now she's a little farther away, not right in that concentrated breath plume of the infected person. Next. Ventilation and filtration are very important layers of protection for reducing the amount of virus in the air. So here we're in a poorly ventilated room where the virus has accumulated, just like cigarette smoke would accumulate in a room with no windows, no doors, and no HVAC system. Next. But if we did have good ventilation and filtration to remove the virus from the air, you can see that the amount in the background there is greatly reduced. There still is that concentrated plume at close proximity situations, and that's where, of course, the mask would be needed to help reduce the risk of transmission. Next. So that's what I have to share today with you, and thank you very much for your attention. I look forward to questions.
Thank you so much, Dr. Marr. Those were some of the best visuals I've seen about these and such comprehensible information. Dr. Pan is going to join us in 1 second, but I just want to say, first of all, we've had a huge range of questions from our registrants and our participants, and a lot of the questions are about outpatient medications. So I just want to refer you all back, if you didn't do it, to the last 2 sessions we had. There was a lot of detail about outpatient medications, what's available, what we expect of availability, and where to find outpatient medications for your patients. You can find those links to review those on covidroundca.org. There are a lot of questions also about testing, and I think we all have tons of questions about that. And I just want you all to know that we have a special session Thursday this week, so in 2 days, with Dr. Michael Mina, who's been a big national speaker on this, and Dr. Wilbur Lamb, who's done a lot of the testing of the home tests for the FDA. And so I think that's going to be super informative. That's in 2 days, so you can register for that at covidroundca.org. And finally, our March topic will be on post-acute sequelae of COVID-19, otherwise known as long COVID, and there are a lot of questions about that as well. So we're going to defer those for today. And I want to dive in, Dr. Marr and Dr. Pan, both of you, and talk a little bit more about masking. So first of all, Dr. Pan, there have been a number of questions just during this session saying, what's the thinking on dropping the mask mandate when cases are still high? And how do you kind of manage that, to balance that in California?
Sure, I think a few things, right? I think we are trying to do things like this to give people good information, and we are learning more and more that that people, I think we're trying to balance sort of all the work over the last 2+ years now at this point of like what we have required people to do and where we have to really, enforce from a government side versus empowering people to do it and educating people about how to protect themselves and their communities. So I think that's a huge part of it, right? Like really, we're still recommending it while rates are high, and certainly in indoor settings, indoor crowded settings, especially if you don't know people's vaccination status, and then we're still protecting the highest risk settings. But I think that is just sort of a general theme that we are moving forward to, right? Like we need to empower our public, we need to educate people to make decisions for themselves about their risks as we decrease the impact on our healthcare system.
Yeah, hard decisions you guys are making, and we really appreciate you being there. So the other question that's been a little bit controversial and confusing is on the other end of the spectrum is about masking in schools. And some people are saying, the the illness maybe is less impactful on children, though when children get it, they spread it to the elderly and they really contribute to the continued spread. But should we still be masking in schools? And I'd love to hear Dr. Marr and Dr. Pan, how do we think about that? Do we have a lot of data on the impact of masks on kids? My kids seem perfectly happy wearing them, to be honest, and don't want to take them off. But is there data that they're harmful for kids?
Do you want to start, Dr. Marr?
I'm not aware of any data indicating that masks are harmful. You know, I imagine, at least from a direct physical health standpoint, just from speaking from personal experience and as a parent of a 14-year-old and a 10-year-old, you know, I think masks do make it harder to communicate. We need to acknowledge that. And, you know, I do think, you know, masks definitely during periods of high transmission with high caseloads. As a parent, I would, you know, I think in a couple of weeks, I would be okay with, you know, my kids not having to wear masks, knowing that there are good options for you know, high quality masks out there for those who want to continue to wear them. But, you know, this is outside my area of expertise, the policy side. And so I'm just speaking as a parent. I realize there are peer pressure things, but, you know, all the evidence suggests that when, at least on the kind of, when we require everyone to wear them, we do see a small reduction in transmission in schools and other places. And we know now that, you know, better masks work better. So that, you know, that small reduction is kind of averaged over people who wear poor masks poorly and, you know, people who are wearing better masks. And if people do wear better masks, I think we would see a greater effect. And those masks are more widely available now.
Yeah, I'll just add a few things. I mean, certainly, and actually the American Academy of Pediatrics has some great FAQs about this and ongoing statements that, you know, to my knowledge, there is not any data to suggest there's any harm. I have actually seen one smaller study even looking at the use of, I think it was a specially designed respirator for children and sort of wearing it for several hours with no differentials. And even in talking to some experts about social and developmental, you know, I have not seen any convincing data about that. And then I think, you know, the harder questions are exactly what we're talking about, and I think equity issues too, right? I think what we really all want is our kids to be in school and to have, you know, to do our best to mitigate transmission. And thankfully, schools have been an extremely safe place to be, especially with masks. That's why we have had that in California for a long time. But again, as we decrease community levels of transmission, we have other tools, we, you know, now we're going to have more vaccines available for even younger children who could be siblings of kids who are in school. I think these are all things that are forthcoming, but you saw our data now in our younger children and how we still have 2/3 of the way to go in California, and we're actually, you know, a state that does have higher vaccine rates. So those are all things that we're taking into consideration. And we really want kids who have been in communities that have been impacted the most to feel safe coming to school. And that's sort of the balance we're all trying to strike.
Thank you for that. Let's pivot, still on masks, but Dr. Marr, early on we saw these cases where singing and choir practice had a major impact on contagion and infection. What's your position on singing and choir practice indoors these days? How can we mitigate risk there?
Yeah, singing is one of the riskier activities. You know, I like to describe it as, well, think of everyone in a room coughing together at once, because that is what you are releasing when you're singing in terms of respiratory droplets and aerosols. We would never tolerate, of course, a room full of people coughing, and I think singing is one of those higher risk activities where you know, do it outdoors if you can. Make sure everyone is, make sure the room is well ventilated, and that is a place where the masking would be especially called for because it is a higher risk activity.
Great, that's very helpful. And speaking of ventilation and things, can you talk a little bit, Dr. Marr, about some maybe affordable interventions for air purification? So, you know, someone asked about their small independent physician's office. What do you do in small rooms without outside ventilation is out of place for HEPA filters. So talk us through that, please.
Yeah, there's a lot of different options out there for spanning the entire price range for filtration in a room that doesn't have windows. Obviously the easiest thing to do, especially in California where the weather's better than in the rest of the country or more pleasant, is to open the window. Even just a few inches makes a big difference. But I've been in a doctor's office where they had a unit, a filtration unit, where I looked it up and it was $5,000. But you know what? I can get the same performance from something that I buy at the local home goods store for about $200 or $300. And even if you don't, even if that seems like too much, there's something called the Corsi Rosenthal box that has been promoted that actually performs better than some of these that you can buy, and that involves a box fan and several different of those rectangular filters that go into our HVAC systems. You can tape that together and you get great performance. It's a low-cost alternative. I think it ends up costing you under $100, and you can get similar, actually better performance than with the more expensive options. So that's something to consider.
Great, that's really helpful. And then just briefly on this, Dr. Marr, do you know about states who are instituting policy approaches regarding indoor air quality? Is this impacting the way that we're going to build buildings and think about regulating places that we're going to be in, and hopefully impact the transmission not only during this pandemic, but also of things like influenza?
I think that might be coming. I know there are discussions happening behind kind of in the background right now. I'm on a committee for ASHRAE, which is the American Society of Heating, Refrigeration, and Air Conditioning Engineers, which sets guidelines for building codes for ventilation. And we are in the position of drafting a new document on kind of HVAC systems and kind of designing and operating them for infectious aerosols. I think that the pandemic has helped us wake up to the fact that it's not just COVID-19 that's transmitted this way, but also flus and colds. Those have a big cost in terms of our health, absenteeism, productivity, kids' academic performance, in addition to other types of particles in the air, which also impact those things, asthma and those same things. And, I am hopeful that we are coming up on a period where we can turn our attention, which has focused so much on outdoor air pollution, where California has really been a leader in setting standards and cleaning up the air over the past several decades, to turning that to indoor air, where we spend 90% of our time. So let's hope that that's coming.
And Erica, do you know, are you aware of any California efforts to think about indoor air quality yet?
I think there's definitely a lot of active discussion about it. I haven't seen the concrete yet, but absolutely, I think this is clearly, especially here in California, we also have, wildfires increasingly are having outdoor air quality, and back to schools, like we want our kids to be in school with, with good air quality indoors. So I do think there are things on the horizon, but nothing concrete that I can share yet.
Okay, great, thanks. Dr. Marr, one other thing that people are wanting to know, and I know there's been a lot of nervousness about the anxiety about this, is we hear that a lot of the masks that we can purchase, particularly on the internet, are counterfeit. And people are just wondering, is there a way to tell, other than like to go to those onerous lists of the ones that are not? And it's a little bit challenging. So one of the participants said, well, he saw some lines that maybe you could see through, and maybe that was a sign it's counterfeit. Any tips there, or we just have to go follow the lists?
Yeah, it's hard. You can't tell just by looking. And I've tested some of these myself. I've seen test results from reputable labs, and there are KN95s out there that are supposed to be 95% efficient, but in fact they're more like 15% or 20%. And again, you can't tell by looking because there's multiple layers if you pull apart the mask, and actually the filtration layer is somewhere in the middle. And even if you pull that out and look at it, unfortunately, you can't tell. I think your best bet is to buy from a reputable seller. There is a nonprofit organization called projectn95.org, which sells N95s, KN95s, and others, and they are a trustworthy source. I know NIOSH CDC has a list of ones that they have vetted and confirmed to be counterfeits, but new ones are popping up all the time. So it's, even if you find something that's not on that list, that's no guarantee that it's genuine and will work the way it says it does. So I wish I had a better answer. I think this is someplace where regulatory action would be and standards would be really helpful.
Thanks. Okay, Dr. Pon, people are wondering, are there any emerging variants that deserve a close watch? We've read a little bit about the BA2 variant of Omicron.
Yeah, great question. BA2, as far as California, I'll say we've seen under 100 isolates, and monitoring in other countries, where it's been increasing, has not increased hospitalizations, but nothing else on the horizon yet.
Okay, and how about other things on the horizon? Any sense, some people got their third booster, or their booster rather, 4 or 5 months ago, and that had started to wane the protection within 6 months or so. And so people are wondering, is there going to be news about the potential for a fourth booster, or a fourth vaccine rather, a second booster? Anything on the horizon there that we know of yet?
Yeah, that's a great question, and I think it really boils down to seeing more data. It's not so clear that, for example, Israel is seeing a huge impact on that. And again, the vaccines are doing their job as far as preventing hospitalizations and deaths. And there's also some of the immunologists will say that, sometimes the third time is the charm. Many of our primary series are actually 3 doses for, in infancy and things like that. So we've certainly been training the whole system to be more prepared. So I think more data to come, and it's unclear, I think, to me, how much will be necessary as far as the waning immunity, especially to prevent against hospitalizations and deaths. And it also, of course, will really depend on how the variants evolve. Like, we know there are going to be new variants, we just don't know if they're going to be more severe or less severe, and how different as far as our immune system's ability to how much immune escape or not. Okay, great.
And another questioner asks about the sewage screening efforts in the state. Oh, we lost Dr. Pond. I was just, they were wondering, is there any coordinated approach to screening the sewage in the state of California, or talks about moving towards that new approach about thinking about transmission?
Yeah, absolutely. We actually just posted our wastewater surveillance website, and I can put it in the chat that we can sort of send out, and certainly happy to do some more highlights about that at a future talk. So yes, I will acknowledge that this is another very much evolving sort of area as far as coming up with standards, but we do have a large network in California that we're monitoring, and we want to increase that reporting into one statewide system. And then the CDC also just updated their national wastewater surveillance site. So definitely a lot of coordinated efforts with public health departments, water resource boards, and academic partners. And again, I'll put a link in the chat to our new dashboard with that.
Great, that's really helpful. And I think we have time for one final question. Just super quickly, any updates on the availability of oral meds, of the outpatient meds? Are we getting more of those now? Is that sort of a steep ramp, or is it still sort of a slow ramp up?
It has still been relatively slow, although a little bit more reliable. And then it is somewhat based on, well, actually it's more than monoclonals, but all of it are allocated a little bit based on our cases too, compared to the rest of the country. So it's one of those areas where as we do better, we may get less. We are being told that, March may be the time that we're going to see a lot more supply in general of treatments and therapeutics. So that's what we are hoping for.
Okay, great. Well, again, I could not be more grateful to both of you, Dr. Marr, from phoning in all the way from Virginia, and both you, Eric and Lindsay, have been so wonderful today. Just a reminder to everyone, please do register for 2 days from now, Thursday, a very exciting talk on testing, and send that to your friends. Oops. That one is currently not planned to be recorded, and so you'll want to be there in person to see that one. And then our next official session is going to be Tuesday, March 8th. So covidroundca.com and I think .org, yeah, I had it written down wrong. And then just a reminder to fill in your email for CME. Have a wonderful day, everyone. Thank you again.
Thanks, take care.